Right. Hi, Lauren. Welcome. Thanks for being on our podcast.
Hi, thank you for having me.
Really appreciate it. So before we get started, just to kind of level set so we're all understanding, explain to people exactly what a speech-language pathologist is and what you do.
Absolutely. So a speech-language pathologist is also referred to as a speech therapist. So you might hear them interchangeably.
Okay.
But SLPs can work with people of all ages, from babies to adults, which is sometimes a misconception. A lot of people assume we just work in the schools, but we actually work in medical setting, private practice, and we work with the whole age span.
Okay.
We treat many types of communication and swallowing problems. So the main categories are speech sounds, which is articulation, language, social communication, so the ability to know how to use language socially, voice, fluency, which is also known as stuttering, cognitive communication. So anyone who has a traumatic brain injury or any neurological deficits, we would be working on them to redevelop their cognitive communication skills. And then what I personally specialize in is feeding and swallowing. And I work in the pediatric age range, which is from infants through about adolescence.
Okay. Yeah. And I'm not going to lie. That's what throws me off is when I got to your website, which I will put a link in the show notes for ThriveSpot, that I had no idea that you actually worked with something, because to me, that's not, quote unquote speech. That's
of course. I know there's a whole movement in our profession trying to redefine our title because it doesn't encompass all that we do, and it sometimes misleads families in knowing what provider, what professional is there to help you with feeding. So but I will clarify that both speech language pathologists and occupational therapists who are trained in feeding are both qualified professionals to work on feeding. And I did want to just highlight for anyone listening who wanted to learn a little bit more about pediatric feeding disorder. An organization that I'm a volunteer with is called Feeding Matters. It's feedingmatters.org. And they're a wonderful organization. They have tons of resources for families who are either concerned their child might have a pediatric feeding disorder, or if their child does have one, there's tons of support, both from professionals and other families who've lived through it. So I love that organization, but I bring it up because they recently advocated to define what pediatric feeding disorders are. And so I'm going to just read the definition because they worked really hard for that. And so pediatric feeding disorder is impaired oral intake that is not age appropriate and is associated with any combination of 4 different domains. So those 4 domains are medical, nutritional, feeding skill, and or psychosocial dysfunction. So they wanted to break those down more specifically and really encompass all of the ways that having any type of difficulty in those 4 domains can qualify you as having a pediatric feeding disorder. And so that's now in the diagnostic criteria. We use that as an ICD-10 code. And so those are the families who I'm working with who fall under that diagnosis. They can also have other diagnoses going on with them that are contributing to the pediatric feeding disorder, but those are my families who I'm working with most of the time.
So as far as children's airway, the way that this kind of associates with us is I can correct me if I'm wrong, it's going to be more on the medical side, right? Because then you're dealing more with jaw development, high arch palates, tongue ties, that kind of thing.
Absolutely, yes. And so the way it also ties in is that I've studied orofacial myofunctional therapy, which is what we'll be talking about a little bit later. And then also oral restrictions or tethered oral tissues, which are more commonly known as tongue tie, lip tie, cheek ties, or buccal ties. So
cheek ties.
Yeah, you can even have ties in the inside of your cheek that can impact feeding. Those don't impact it the most when you're comparing to the tongue and the lip, but it's all relevant to each individual. So I've done continuing education in those areas, but they all tie into airway because everything starts with our airway. And if our airway is not intact, and if we are not able to adequately breathe through our noses, which is what we're supposed to be able to do, it then kind of has a ripple effect on the entire oral facial structure, development, and the functions in which we use our mouth, our nose for. So breathing, speaking, and eating.
And eating.
So that's kind of how it all ties in, because those are the areas that I'm working within. And the airway, of course, dictates so much more than most parents and people know that. That's why I'm so glad that you're bringing awareness to this whole topic. And I love everything that you guys are doing. I think it's wonderful.
Yeah. Well, thank you very much. Yeah. And I will say, kind of on a personal note, I grew up with a speech impediment. So I worked with a speech language pathologist, which if anyone ever listens and they hear me slow down, that's what I'm doing, because I know what's about to happen with my sounds. But one of the things that surprised me, when I was reading, I did go to your website and did a lot of reading. These kind of things, even language, somebody that has an impediment like mine can impact your breathing. It can impact how you eat. It can impact, I never really thought of that. I just thought it was, an annoyance. When you talk, you stumble sometimes.
Yeah, it's really, it's wild how everything is so interconnected. We learn about things in such silos, like this is your speech, your mouth is for speaking, your belly is for digestion, your legs are for walking, but literally everything in our whole body is very interconnected. And when one system isn't working, it's usually impacting another one in a different way, or it's usually tied to that. Maybe there's a problem in a different system that's impacting your other system. So yes, our whole bodies are so interconnected. And I think that's one thing that is lacking in a lot of the education programs, is just how interconnected every system is within the body, including starting with the airway. Right,
which is crazy. So, all right. So let's just say you're working with a child with an impediment. And first of all, just to clarify, if a parent has a child like that, I'm not trying to send anybody into panic. Your child doesn't have an airway issue. We don't know that, but
of course.
We'll just start with that and kind of work our way into the more airway impactful ones. What kind of training and work would you do with this child? I mean, obviously it's age dependent.
Yeah, so it's for sure age dependent. And so we're typically talking about kids who are, 2, 3, 4 or older. Obviously, we're seeing more speech development come in closer to like 3. You should be saying words and phrases, of course, but we really don't address articulation or speech sounds until closer to 3 or 4, because most sounds are still developmentally coming in up until that point. And some are even coming in later than 4. So we're talking 5, 6, 7 for certain sounds. So we would assess the child and look at the errors and the patterns, because there are different indicators that would tell us how we would address it. So for instance, children who are younger often exhibit what we call phonological processing sorry, let me try that one again. So children who are younger will often exhibit phonological processing disorders. Okay, so that is basically patterns where they simplify sounds in words in order to kind of make it easier for them to say. So an example of that would be if you have what we call a cluster, which is an SP sound. So in the word spoon, you might hear a younger child say poon instead of spoon. So that's a typical error sound up until a certain age. It's normal for kids to do that up until a certain age, usually like 3, 3.5. If it persists beyond that, then we would assess and determine if there are patterns like that they are exhibiting, then we would address it in a certain therapeutic way versus just more of an error that is not a pattern in terms of the phonological processes. So that's kind of above this conversation a little bit, but so we would assess their articulation and look at what age they should be saying these sounds, and then go from there and decide how we would address them based on how they're presenting. But we would always be looking for if any of their signs or symptoms of speech difficulties are pointing towards an airway problem. So what does that mean? So that would basically be if we're seeing children who exhibit a tongue thrust, which is basically when you see the tongue pushing forward.
Okay.
With
Okay.
certain sounds. Sometimes people describe it as a lisp. There's research out there that's showing that that could be indicative of an airway concern, because the tongue is pushing forward to try and open up the airway,
Yeah.
a bit. So that's kind of some newer research that I've been hearing about and learning about. But
okay.
But to go back to your question, it depends on the child's age. If they're older than 4 years old, then I would be assessing them from an orofacial myofunctional standpoint, which is different than a traditional articulation assessment. But if they're younger than 4, then we would be using different assessments because of the developmental age levels that I mentioned before and when the sounds are coming in.
Okay. Yeah. And you just touched on the orofacial myofunctional disorders, which that's a mouthful in and of itself, right?
It is a mouthful.
It is. So let's talk a little bit more about, what that is.
Yep.
And then, what the disorders are, what parents can look for, just to give them a better understanding of all of it.
Absolutely. So it is a mouthful. So for the sake of that, I'll probably refer to it as OMT, which is orofacial myofunctional therapy.
Okay.
Or if you hear OMD, that's orofacial myofunctional disorder. Okay.
Got it.
So I'm hoping that this becomes more common knowledge, because they're now starting to require that be taught in graduate programs. But when I was in graduate school, it wasn't included in the program. So, but hopefully, hopefully that will become more familiar to people. They won't think, what was that mouthful?
Right.
Which is very much the reaction I get when I talk to anyone about it. But I like to describe it based on the goals that we work on when we're addressing OMDs. So the goals of orofacial myofunctional therapy are to establish nasal breathing, both day and night. That's the first one. Okay. The second one is we want the lips touching lightly at rest. The third is we want the tongue position to be up in the palate and just behind our teeth. Okay. And we want that to be whenever we're not speaking or swallowing or eating. And then the fourth is what I just mentioned, correcting swallowing patterns, which if you're seeing someone who's trained in orofacial myofunctional therapy, they will be either a speech-language pathologist, an occupational therapist, or a registered dental hygienist. If you're seeing an RDH, they can't work on the swallowing part of it because that's not within their scope, but the OT and the SLP can. So I would be addressing if there's any feeding problems associated with it, and also any speech problems that would be associated with.
So quick question on the swallowing. Obviously, and we'll dig into this a little bit more about, nasal because of mouth breathing. The rest of them are pretty, I think, intuitive, but swallowing, how is that a sign of an airway issue?
So I like to use the example of a tongue thrust pattern, which we kind of touched on a little bit before, but sometimes what adults, children, we see it throughout the age range, they thrust their tongue forward instead of what we want to see, which is like a peristaltic wave where it goes up and kind of back as you swallow the food or liquid or saliva. And oftentimes that's a red flag for an airway issue for the same reason, because they're pushing up against the teeth instead and almost opening up the airway to breathe while they're trying to facilitate the swallow as well.
Gotcha.
So then the other problem with that is that they're shifting teeth. And so you often will see
shifting teeth. So
what we call our malocclusions are different bite patterns and essentially crooked teeth in certain ways. So a overbite, a deep bite, overjet. There's a lot of different terms within malocclusion that I trust my RDHs and my dental professionals to speak on more comprehensively. But when we see children or adults, but primarily children with super crowded teeth, that's usually a red flag for us as providers that their palate is probably too small or narrow, because their tongue was not resting up inside the palate to give it that good U shape. So what we want is the U shape, the nice broad, wide U shape. Instead, what we are seeing sometimes is this more narrow V
like
shape.
a V, yeah.
And then when the teeth are trying to come in, they don't have enough room because it's not nice and wide from the tongue shaping it. And so then we get crooked teeth. And depending on how they're using their tongue when they speak or swallow, that can even further shift the teeth, because the tongue is a very strong group of muscles. And if it's constantly pushing in certain directions, it's going to shift things. So that's how we actually get the shape of our palate, is by keeping, we want that tongue to be up within the palate so that it does keep that, U shape. But when it doesn't rest up there, that's when we start to see that it doesn't hold its shape as it would otherwise.
Okay.
Yeah. So that kind of are the goals of orofacial myofunctional therapy. There are some causes that can contribute to these. So some of the causes, the number one, which is why we're here talking today, is airway obstruction. So what could be an airway obstruction? So if a child is not breathing through their nose, we would want to figure out why. So we would want to know if it's enlarged adenoids, if it's enlarged tonsils, if there's a deviated septum, if there's seasonal allergies or recurrent allergies to food, or something that's causing congestion all the time and forcing them to breathe through their mouth. So the airway is what we look at first and foremost, because that's the most important to the overall function.
Okay.
And in order to do that, we would assess for if they can breathe through their nose. So for instance, we could have them keep their lips together and see, like, are they able to breathe through their nose for short periods in our assessment? And if they're struggling, we would be immediately referring them to an ENT first, possibly an allergist, to further evaluate these things, and try to rule out what is contributing to them not being able to breathe through their nose.
Okay.
So airway problems are the first thing we would want to look at. And throughout most of this process, there are more than one provider that may need to be involved to help support whatever's happening with the child.
Okay.
The next one would be oral habits. So that would include things like finger sucking, thumb sucking, extended use of the pacifier, even nail biting. If you're someone who all the time sits with your face on your right fist when you're listening in class or when you're talking or anything, eventually having that fist there is going to shift things in your mouth and your face. And so there are habits that we may not even realize that could be contributing, but the bigger ones are the sucking habits, sucking on anything. Some kids suck on their t-shirts all the time, or their necklaces, or so the sucking, we want to figure out, well, why do they need to suck? What is the reason? Why are they still sucking that thumb beyond the age of, 1 or 2? And we often look to the airway to see if that's helping support their airway almost, because when we suck on our thumb, we're jutting our jaw forward a little bit, which is then opening up the airway a little bit more. So we want to look at, is that part of the problem, or is it that they just enjoy the soothing aspect of sucking still, or is it both? So oral habits aren't always as straightforward as people think. And I've learned through orofacial myofunctional therapy that these kids that we see who are still struggling to get rid of sucking their thumb, in like almost even 8, 9, 10-year-olds, that's usually a sign that there's something else going on with their airway. And that's why they can't give that up. So we would really want to dive deeper into what's going on.
Okay.
And that would be through an orofacial myofunctional evaluation that would then inform us as to what other professionals would need to be involved to help alleviate whatever's happening. So then the last one that I wanted to mention that can contribute to an orofacial myofunctional disorder is those tethered oral tissues, the tongue, lip, tie. When, and I don't want to get too nitty gritty because I might mess up some of the details, but swallowing starts in utero. After that first trimester, babies are able to swallow in utero. So when they are born, the patterns that they're showing, they didn't just start doing the swallowing when they're born. They've been doing it for months in utero. So when they're in the stages of development, they're finding that the tongue tie and the lip tie form early on in development as well in utero. And so they're swallowing with that tongue tethered or low lying in their mouth. And so their palate is not forming correctly because it's not able to reach the palate when they swallow.
Right.
So these anatomical and physiological problems that we're seeing when they're born are happening in utero sometimes. So anyway, that's why we see kids who are right off the bat are having trouble with latching to the breast, or even bottle feeding. It can impact. However, when we see these children who are a little bit older, who maybe were missed with the tongue tie, what we see is that their tongue is lying low, which is then not shaping their palate, which is causing those malocclusions, those crooked teeth, which is also putting them at risk for the sleep disorder breathing. Because if you have your tongue lying low and you can't, or you're not used to getting it up in the palate, when you lay down, gravity pulls it back and it sits further into your airway. So your airway space is then shrunk down even more. And that's forcing you then to breathe through your mouth more because you're not getting enough through your nose. So,
and is it fair to say for parents that, you know, if you see a child breathing through their mouth consistently, it's not just, you know, one night they have a stuffy nose, that there is an issue. It's worth, you know, pointing out.
Yes, absolutely. So if we want to just dive into that topic, because I know that was something we were going to chat about, how can you tell if your baby or child is mouth breathing or might have sleep disordered breathing issues? So I think we kind of said this, but when babies are born, they're supposed to breathe through their nose. We are born as obligate nasal breathers. So if a baby cannot breathe through their nose, they're going to be forced to breathe through their mouth. Same with a child, right? They're going to go to the mouth to help them breathe because they need oxygen to live. Right. But we're supposed to be able to breathe through our nose. So why is that important? Why do we need to breathe through our nose? Okay. So there's so many reasons that nasal breathing is beneficial. So one, and this is not covering all of them, this is just going to highlight a couple. Nasal breathing filters airborne pathogens. So when we are breathing through our nose, it's a filter. It's kind of sorting through those germs, getting rid of some of that bacteria. If we're breathing through our mouth, we are not getting that same filter. So that means you're more likely to get sick more often. Okay. Nasal breathing allows for nitric oxide to be produced. This is a complicated topic, but if you look up nitric oxide, there's so many benefits and so many functions that let me say that one again.
That's okay.
So nasal breathing allows for nitric oxide to be created. And nitric oxide is super important. One of the things that it does is it allows blood, nutrients, and oxygen to travel to every part of our body efficiently and effectively. So if we're not creating enough nitric oxide, we're not seeing those benefits, which can then lead to other hosts of issues, health issues. And then another thing is nasal breathing serves as a natural bronchodilator. So it opens up our lower airway, the lungs, the bronchi. It helps regulate what's called heart rate variability. And that's a good thing. We want it to regulate heart rate variability because that's a really important thing as well, which I'm not going to comprehensively explain well. So I will just encourage you to look that up and understand how important it is, and how nasal breathing does play a role in that. And then the last thing I wanted to mention, go ahead.
Oh no, I was gonna say, and we'll put a link. We have a blog that kind of touches on this. So we'll put a link so they can click through and read more.
Perfect. And the last thing I just wanted to mention was that it activates the parasympathetic nervous system, which is the rest and digest part of our nervous system. And if we don't activate that part of our nervous system, then we become very dysregulated. And then that also in turn impacts our sleep and whether or not we're getting that restful, restorative sleep. So again, you're hearing how a lot of the systems are tied together. And we really don't realize it until well, it's educated until we spread the word, right? And that's what we're trying to do.
That's exactly right. That's exactly what we're trying to do. So one of the things, and I have some other things, but I just wanted to kind of go back to, because you touched on something that I don't think a lot of people really comprehend. At one of the things that Children's Airway First that we're advocating for is this full examination, oral examination at birth. That just doesn't happen currently. And you touched on it and why it's so important. I just thought maybe we could talk about that for a little bit. That, as you mentioned, these things are formed in utero. So if somebody took the time at birth to look, you'd find a tongue tie, or you'd find that V-shaped palate that, where it's still malleable, you can kind of adjust it.
Well, so it would, if we identify these things right off the bat, it would better inform our decisions throughout their early life. So if we are able to better identify these things, we would better be able to support their feeding journeys, right? So many moms I talk to say, I just couldn't breastfeed, they couldn't latch, right?
Yeah.
And there's very few cases where it's an issue with the mom, although it may feel like that to the mother,
right?
How hard the struggle is.
Mm-hmm.
It's usually because there's some sort of oral dysfunction with the baby. And that's not to say it's always a tongue tie. It certainly is not. But if we can identify if it's because of that high palate, so they're not able to get that good suction on the breast to latch. If we can identify those things at birth, not only will it set the babies up for more success, but I think that it would also really largely impact that mother-baby dyad if they do want to breastfeed. Yeah,
absolutely. And also just the mother's emotional journey afterwards, because that's hard when you can't do that. That is absolutely hard.
Yeah.
Right, so there's a quote before we move into our next section that I wanted to read. That is from an article that I know you're gonna mention, and I will put the link in the show notes. But the quote is, the vast majority of healthcare professionals are unaware of the negative impact of upper airway obstruction, which is mouth breathing, on normal facial growth and physiological health.
Yes.
And to me, that whole article, which again, it's a little bit mind-blowing for me, but that statement, here we are in 2022, and that's still just not really understood by most.
Yes, I totally agree. I think that, so that article is Healthy Breathing Round the Clock by Nicole Archambault. And there's some other articles that I'm drawing a blank on the name of it, but there's a quote where this dentist is saying that it's this hidden airway epidemic. Like all of our children, every single person who works with kids, whether you're a teacher, a dentist, a doctor, a speech therapist, a daycare provider, if you are someone who comes into contact with children, you need to be educated on the risks of mouth breathing and sleep disordered breathing because of how detrimental it is to their overall development. And in that article specifically, it states quite a few statistics on how sleep disordered breathing, which is tied to mouth breathing, impacts behavior, cognition, and is misrepresented as ADHD sometimes.
Absolutely.
There's quite a few.
Article by Kevin Boyd, just out of curiosity.
Yes.
I'll make sure that one is linked in here as well. I've got that one.
Absolutely. That's a great one.
We know Kevin Boyd very well.
Oh, wow. That's wonderful.
Yeah, he's actually one of our board members, one of our advisory board members. Yeah, phenomenal. As soon as you got to the point about behavioral and cognition, I knew which dentist you were referring to because Dr. Boyd has taken this to such, it's not just, he looks at it from the traditional medical perspective, but he also has an anthropological background. And he's got this really brilliant article that really ties it together with, these behavioral outbursts or how much impulse control you have. And that somehow ties into airway obstructions. It's a sign.
Yeah. And just to touch on that, I kind of was prepared to chat a little bit about the ADHD misdiagnosis.
Let's do that, because that is
Yeah.
very common with children with airway disorders. Somehow are labeled and misdiagnosed as having ADHD. That's not to say everyone with ADHD has an airway disorder, just to
Right.
clarify.
Right. And to be clear, I think the message that we hope parents will take away is that when going through the process of diagnosing a child, we hope that sleep and breathing and airway will be taken into consideration and looked at before any child is labeled with really any diagnosis, because of how detrimental sleep disordered breathing is on the brain and the behavior of our children and adults, actually.
Right.
Which is wild. But so what I was going to say is, when your child is living with sleep disordered breathing, their brain and their body are essentially sleep deprived, because they are not able to enter into REM sleep, which is the phase of sleep when our brain is restoring or fixing itself, and all of the little problems that build up during the day. So without REM sleep, we see some or all of the signs of sleep deprivation, which you will notice are many of the same signs that we see present in children diagnosed with ADHD. So here are some of the signs that I took from sleepassociation.org of sleep deprivation. So the impairment of cognitive functioning, impacts on your stress hormones, disrupting your cognition and destabilizing your moods. For some, this can cause more volatile and intense reactions to everyday life stressors or situations. So what may seem like a small task may turn into a huge production. And it can also make you irritable and angry. And I don't know about you, but if you've ever been sleep deprived, you've certainly experienced
of course
the impact that it has on your patient, your ability to focus, your ability to function and do your job. So now let me, on the flip side, read you some of the diagnostic criteria for ADHD.
Okay.
So it often fails to give close attention to details or makes careless mistakes in schoolwork, at work, or with other activities. Often has trouble holding attention on tasks or play activities, does not seem to listen when spoken to directly, has trouble organizing tasks and activities. So all of these things are consistent with signs you would see when someone is sleep deprived.
Right.
So it begs the question, is the child truly experiencing attention deficit hyperactivity disorder, or is their brain sleep deprived? So what we would want is for physicians to say, hey, how is your child sleeping at night? Like, let's take a look at some of these signs and symptoms that might indicate that they're experiencing sleep disordered breathing, or that they're not breathing effectively at night. And a lot of times I like to say to parents, once our babies are sleeping through the night, we don't go in and check on them regularly. We may check on them right before we go to bed, but we're not listening to the monitor anymore. We're not hovering over them, making sure they're okay. And we might not realize that they're thrashing in their sleep, that they're talking in their sleep, that they're grinding their teeth or snoring or gasping for air. One of the things that I like to touch on is that extended bedwetting. Like, if a child is having trouble with mastering, holding their urine throughout the night, that can often be an indicator that they might be having trouble with sleep disordered breathing.
And you say extended, so at an older age, we're talking like 6, 7, 8. Okay.
Yep. So if it's past past 5, 6, 7, 8, and we're not really figuring out why are they still having this trouble? It's not always because of sleep disordered breathing, but it's one thing that should be looked at, that most parents wouldn't, and most really pediatricians aren't speaking about. So, but it's really, there's a couple different ways that it causes extended bedwetting. I don't really know if you want to dive into it.
No, I absolutely would, because that is something I wonder is, how is that connected? Because that's one of those things that just isn't obvious to me.
Yeah. So if we're talking about a kid who has what we were referring to as low tongue posture, so their tongue is lying low in their mouth. It's also sitting back into their airway, as we touched on. And when they lie down, gravity is making that airway smaller. And so if they're mouth breathing, then they're not exchanging the right amount of oxygen and carbon dioxide. And if you have an excess of carbon dioxide in your system, that can contribute to relaxing smooth muscle. And our bladders are
Oh,
smooth muscle. So then it's relaxing the muscle and then we're peeing. Okay. So that's one way that it can contribute.
okay.
Another way is that a lack of breaths in the body. So we're talking about sleep apnea. So a child who's having so much trouble breathing that they may stop for a short period of time and then gasp for air. So that lack of breathing then can signal the heart that the body may be in fluid overload. And so it then signals the kidneys to release urine and fluids. Okay, so the body is like, oh my gosh, we're in fluid overload. Like, let's just get rid of some of this fluid. And then the third way is that if we're not getting oxygen in, we go into fight or flight, and everything in our system is focused on our breathing so that we can survive. And so it's forgetting about our other systems,
Everything
like
else.
holding your urine, and it's that system is ignored in order to prioritize your breathing. So so those are three ways that it can contribute to, or it can be linked to sleep disordered breathing.
Okay.
Which I like to chat about, because when I was first learning about this, I was like, what? I had no idea.
Right. And it's funny. And thank you for explaining, because in all honesty, I've seen it on lists several times. I've never been able to make the connection.
Why.
Yeah. It's like, why, how is this possible?
Yeah. I learned that from Autumn Henning, who's a leader in our field. She's an orofacial myofunctional therapist, a speech-language pathologist, and a certified lactation consultant. So she's an educator in the field, and she explains it so well. So I will attribute knowing that to her.
Awesome. That is absolutely awesome. All right. So I'm a parent, and I'm noticing that my 3-year-old, let's say, is snoring, which up until I started working with the foundation, I did not realize was not cute. They don't grow out of it. It's a bad thing. So as a parent, if I see something like that, or I'm noticing my child has that kind of worried expression when they swallow or drink, what do I do?
Okay, so I always tell parents that if you have concerns, your first stop is always your pediatrician, but it shouldn't be your last stop, because oftentimes, and I'm not blaming pediatricians by any stretch, because they have so much that they need to be responsible for, but they are not the specialist in these areas. So if they say to you, they don't have any huge concerns, but it's still something that in your gut, you're thinking, but I don't think this is normal, or I think there's something more to it. Then depending on what the concern is, I would find a specialist within that area of concern. So if it's something that has to do with feeding, I would be looking for a feeding therapist, which would be either the speech-language pathologist or the occupational therapist. But you have to make sure that they have that training in feeding, because as I mentioned, not all graduates come out with extensive training. It depends on their program. And so if they've taken a special interest, there will be continuing education courses, and they'll be able to speak to their years of experience in working with families or clients with feeding disorders. So if there's a feeding concern, you'll look for the SLP or the OT with experience. And if you're looking for, if you're concerned about breathing, first, of course, is the pediatrician. Another one would be an ENT. I would say to ask your pediatrician for a referral to an ENT and say, I totally respect that you're not overly concerned about it, but it would really make me feel more comfortable if I could see the ENT and really have them either scope or look and give me their insight, because it's just really something that's been on my mind. And hopefully the pediatrician would be willing to refer you to the ear, nose, and throat doctor.
Right. Yep.
And then the other professional would be the orofacial myofunctional therapist. So why I say them is because their role is really like they're the umbrella person almost. So they will look at the whole function of what's happening, and they will say, or we will say, this is the professional that you need to see to rule out XYZ. So we'll be able to kind of parse out what contributing factors might be the most salient thing to look at first, and then point you in the direction of the provider who we think is kind of looking at it with the same eyes as we are from the airway perspective. Obviously, all ENTs are looking at the airway, but sometimes you'll hear parents say, the ENT said the adenoids weren't that bad. They were only taking up 50% of the airway. Well,
Only
50% of
is
the
a
airway
lot.
is pretty
Right.
substantial.
Yeah.
So, not all providers are created equal in any profession,
Sure. Absolutely.
So oftentimes the orofacial myofunctional therapist has been referring to different providers and knows a little bit more as to who will be looking at it with the same lens that we would be looking at it with, and kind of like looking more closely at those specific concerns. So those are the places that I would go. Did you want to ask something, or did I interrupt you?
No, you're good. Well, I mean, it's a follow-up question, and that is, do you have to be referred to a myofunctional?
So it depends on what route you're going to go. So
Okay.
many orofacial myofunctional therapists may be out of network. If they are out of network, that means that they may not take insurance, but they may provide you with a super bill that you can submit to your insurance for reimbursement. So what it would depend on is what your insurance requires. So if your insurance requires to have a referral, you would want to just call them and check with them first, so that your likelihood of being reimbursed for a portion of the cost is more likely if you know what the insurance is requiring. If they're in network, again, you would have to check, but it just depends on the facility. If it's a private practice, oftentimes they don't require one, but if it's affiliated with a hospital, like an outpatient center, they might require a prescription or a referral.
Or a referral. Okay.
Yeah.
Awesome. Yeah. Well, and as we wrap up, I just open the floor to you at this point for any final thoughts, any things you want to share, guidance, anything for parents.
Yeah, I think that I want parents to know that the first thing is to follow your gut. If you feel like there's something going on with your child, if you're seeing these behaviors, if you're hearing noisy breathing, if you see some questionable feeding things, follow that instinct, and don't stop with your first Google search or your first provider who you ask. If you feel like something's going on, just don't stop until you talk to someone who you feel is really adequately answering your concerns, and helping lead you in a direction that you feel is acknowledging that. And then I would say that if any professionals are listening out there, it's our role, it's our obligation to try and continue to spread the word about airway and sleep disordered breathing and why mouth breathing is a concern, and try and help educate anyone who's working with children, but also parents, so that they can be their own best advocate and really advocate for their kids and get them on the path that they need to be to be successful in their development.
And I applaud that. So thank you very much. You said that beautifully, and I appreciate that. And thank you so much for being on our podcast and really and truly just shedding the light on quite a bit of information that I think a lot of us either misunderstood or just didn't really fully understand. So thank you.
Thank you so much. It's an honor to be a part of it.